So, yeah, this is not one muscle, one vision. Probably we'll have to do more when there is a torsion with the thyroid ophthalmopathy. She is a 35-year-old lady, came with the euthyroid status, prominent eyeball since 1.5 years when she was presenting to us. She was taking IVMP, and this is the situation what she came to us. Typical thyroid ophthalmopathy, which presented to our oculoplastics clinic with the very huge proptosis on both sides. You can see this very huge at 37 years, and she was doing microscopic surgery. She had a significant difficulty with that, and obviously, imaging helps. Here, you can see most of the muscles are except the lateral rectus is involved. The superior oblique also can be involved in thyroid, but it's not involved. So our oculoplastic colleague, Dr. Milind Nayak, he did the three-wall decompression for this patient. This is the left eye and this is the right eye. And this is the post-operative picture. Significant improvement in terms of proptosis. You can see the pre and post-operative, almost 4 to 8 millimeter difference was there. And there is some asymmetrical improvement if you can observe there. And after follow-up, at 2 months, she is coming to me with the double vision, which is mainly torsional. You can see the alignment looks okay, but she says she cannot look up. She is always with the chin up position, and she is seeing everything torsion. So that's her, if you see the ocular motility, there is some abduction limitation and a significant elevation deficit on both sides. If you look at the ocular motility measurement, obviously light eye looks a bit higher than the left eye, and in down gaze she is orthotropic. That's why she is always keeping the head tilt up. And her main problem is the excyclotorsion, which is 10 degrees on both sides. So what does it say? There is excyclotortor is very, very strong, probably in this case is inferior rectus. That's why she has a 20 to 30 degrees of chin elevation in this particular case. So what do we do here? If you just take the right hypertropia, you would do a small recession of the left inferior rectus. So it may not be enough. You know that already the muscles are thick. I always repeat this imaging just before the surgery, because sometimes the inferior oblique displaces after decompression. Sometimes muscle pulleys are different. Here you can see still the medial rectus is very, very thick, but it's not causing any esotropia. But you could see the abduction limitation, and you can see this muscles. They are hyper intensity. Within that, you can see. I call it as a mitochondria looking muscle. This is because of the fat infiltration of this muscle. This is common in thyroid. You can see both the muscles are very, very thick in this patient, inferior rectus as well as medial rectus. So intraoperative, obviously, this has to be taken for surgery. Inferior rectus was tight. And after disinserting the inferior rectus, I checked for traction test of the superior oblique. It was negative. What we did is asymmetrical recession, 4 and 5 with nasalization. I think Deepthi was talking about it. This is what we have done in this particular case. We had to do bilateral because the elevation was deficient. She was not able to look up. So we wanted to release that restriction, and also we had to take the excyclotorsion effect of this particular patient. So this is after the surgery. She had a small hypotropia with encyclotorsion. This is on the first post-operative. And after that, she was okay. You can see the elevation also a little bit improved. No torsion on double Maddox rod. And obviously, you can see still there is a retraction in spite of taking care of everything. It's a 4 and 5. Still, it causes the inferior rectus scleral show is there. And this is in terms of her fundus picture. It's okay. It's not perfect, but she has improved significantly pre and post-operatively. This is something I am worried. That's why I learned from Dr. Parulekar and also Dr. you also explained. Can I have the summary slide? That's the last slide I just wanted to. Yeah. Torsional diplopia can happen in TED. Cover test may not uncover it because you would do cover test and you will think what's happening in this patient. Double Maddox rod is helpful. Fundus photo, I could not retrieve the preoperative fundus photograph in this patient. And always when there is cyclotorsion, look for the oblique muscles as well. So IR weakening with nasalization can help in these patients. Thank you very much for your kind attention.
Thank you, Dr. Ramesh, for the very interesting lecture. And now I want to ask Dr. Ihab El-Babli, would you go in all your cases with superior oblique palsy for simultaneous tucking and the inferior oblique recession at the same? So I want you to clarify when you did this in this case.
And the head tilt was more than the hypertropia. That's why I tried to correct the torsion with more tucking of the superior oblique and was under action of superior oblique muscle, but I didn't do a lot of tucking because tucking can cause browns.
Yes.
You see here in this picture, there was some restriction of elevation, but after 6 months it disappeared. That's why I did only 4 millimeter of tucking of superior oblique as well as recession of the inferior oblique. Sometimes I'm doing superior oblique muscles or inferior oblique muscle with contralateral
inferior
rectus.
Okay.
It is according to the reason and the measurements.
The measurement. So the main problem in the case was torsion. Torsional. So
and
you
the
made
application was high as well, so more than 14. But you need
14.
Yeah.
Okay.
But you see the vertical fusion because it's a congenital condition was very good.
Yes.
So he could it could go out more than 14 prism diopter. That's why I did 2 muscles at the same time. If I did only inferior oblique session, it wouldn't.
It wouldn't help. So I was trying to ask you about why did you choose to do superior oblique tucking, not the contralateral inferior rectus recession, and you clarified this point for the audience. Thank you, Dr. Ihab. Dr. Ramesh, how long you wait after orbital decompression before going to muscle surgery?
Somewhere around 4 to 6 months is what I would wait. And in the meantime, any kind of prisms which can help, I try to give, not in this particular case. So I would say around 4 months minimum.
Around 4 months, and yes. You gave the patient ground in prisms.
Ground in or Fresnel prism, depending upon what the situation is. If it is around less than 10 PD or so, I would give a ground glass prism. Otherwise, if it is more than that, Fresnel we try to give. And I don't give anything if it is beyond 20. It becomes very difficult for the patients to really be comfortable.
Okay. So, Dr. Sumita? Okay. So, may I ask you, in such cases of inferior rectus nasal transposition or temporal transposition to help correcting the torsion, do you have any titration for these cases?
Titration of nasalization?
So, of nasalization of the inferior rectus.
Yeah. So, I think it's pretty much what Dr. Ramesh did is what I follow. About 5 to 6 millimeter of inferior rectus recession, only half tendon transposition, and beyond 6, if I have to do beyond 6, the technique that I follow is the intraoperative relaxed recession, wherein perform an FDT and say the inferior rectus falls 8 millimeter behind the original insertion site, then I fix it there. So if I have to do 8 millimeter recession, then I will do a full tendon nasal transposition.
Okay. Mm. So, do you have you ever seen Dr. Hoppen a case with? Have you ever tackled an inferior oblique weakening procedure in cases of thyroid? You find it out tight? No. Dr. Ramesh, have you ever seen this?
I've done one patient where the patient developed a brown kind of picture.
Yes.
Actually, after decompression, there was some restriction of the inferior oblique. So I had to do some kind of release of that muscle.
You never tackle it in the first intervention.
No.
If you have this problem after your first intervention in the second time,
yes,
you would go. So you would never pick it up, tight inferior oblique, as a part of the tight muscles as a result of the thyroid eye disease.
You can pick it up post decompression surgery if there is a elevation in adduction limitation, along with your imaging does not show any thickening of the inferior rectus. That cases probably I will look into the inferior oblique muscle and explore it. Otherwise, I would do the inferior rectus first and then come back to the inferior oblique.
I do not have the courage to tackle and be sure that the inferior oblique muscle is very tight due to thyroid eye disease, except after I correct the other muscles that are already tight due to thyroid eye disease. So that's why I'm asking you this question.
Yes. I just had one comment about that superior oblique because
please go ahead.
If the deviation is around 20 or within 25, one muscle weakening, very severe weakening of inferior oblique is enough, except if your oblique or the traction test, force traction test, or your imaging shows very lax or diaphanous superior oblique, then in that case, we have to do a superior oblique tuck.
So you depend on the superior oblique traction test.
Yes, it's very, very important to perform in these patients. Yeah.
Okay. Dr. Walid, please. Dr. Ihab, okay.
Question. You are doing hang back for the inferior rectus always?
Inferior rectus, I'm super careful. I used to do 7 and 8 and things like that. I've stopped doing it. I don't do the hang back. I do additional. This particular patient, I had to do a nasal transposition. There I do additional because when you do this, it can just slip, and if it is too tight, I put additional suture rather than just hang back. No, not hang back, not even hemi hang back. Yeah, they are anchored somewhere, and then hang back is I feel it's very. No, I didn't do the hang back. It's something like progressive overcorrection of inferior rectus. Even if you do non-absorbable suture, it can happen. So it's very, very notorious muscle in thyroid. So I burnt my finger once or twice. So I am very, very conservative in terms of inferior rectus recession.
How much was the excyclotorsion?
Excyclotorsion was 20 degrees in this particular patient.
When you take the inferior rectus, the lid retractus along with it, so you specifically use non-absorbable suture or absorbable? Or if you're not taking it and just recessing IR, so is there any suture difference between the two?
No suture difference. If you want to take what I explained, the Manoj's technique, if you want to take the retractors also, if inferior rectus recession, the insertion is here, when you do the recession, it comes down. Your retractors also comes down. So you have to put the retractor here. For that, I use a normal conjunctival suture, 80.
Any questions?
Mentioned before, in the thyroid, we have to control the thyroid. In any thyroid, what you will control so the condition can be progressive. This is a problem.
That's why it's not about endocrinologist giving an approval whether you can go ahead. Euthyroid, mostly it is nothing. One thing you can measure is the disease activity. I didn't go into the scores and all that. There are a lot of active scores for thyroid. Once you make sure that there is no activity in euthyroid, you can go ahead. One more additional thing you can do is the TRAP, the thyroid related antibodies test. You can do it. If they're positive, probably you can put them on some immunosuppressant. So even euthyroid, just controlling thyroid is not enough. So if you have some antibodies, then probably you can go into it. But that's why I give that additional time of 4 to 6 months before we really consider anything else for these patients.
Yeah, I had a question. So when you are again suturing up the capsular, but back you're putting it at the new insertion of the inferior rectus.
Yes, new insertion. This is something very recently I learned from Dr. Parulekar from Birmingham. Yeah.
Yeah, because you invariably find a retraction when you
It makes, because one is the retractolysis, one is conservatively saving it so that it does not pull it. Otherwise, invariably, that's a very dangerous, the inevitable complication we have in thyroid patients.
and when you fix the inferior rectus and you put a fixed suture, then you put additional